lab, I did a clinical study, and it turned out that 20% of the people with the thoracic aortic aneurysm or dissection had another family member, really indicating there was a strong genetic component. And we started working on trying to find all the genes that predispose. And one of the first families that participated in our study was this family. This is a pedigree where if you're affected, males are squares and females are circles. And people that are married have children. If it's blacked in, the person's affected. And so this is a family where you can see this is the affected indicates who has aneurysms and dissection. You can see it's being passed from one generation to the next. And we had told this young man that he had the gene and that he was at risk for dissection. And he kind of, I said, get in and get imaged. And okay. And thank you. Pointing out the obvious to me. And get in and get imaged. And he kind of blew us off because he was in college and he started having chest pain, which is the #1 feature of a most common symptom of a dissection. He went into 3 ERs. They all sent him home and said, you don't have Marfan syndrome. You know, it doesn't run in families. And 3 hours after his last ER visit, he was dead of a dissection. And so that really made it was like a slap in the face for me, because it made it clear that we were doing all this research to show that it was inherited in families beyond Marfan syndrome and people that look completely normal, like ACTA2 patients. And that it wasn't, even though we had published many, many papers, it wasn't getting translated into preventing deaths. And so Tyler Cayley's death really changed my approach. And I started advocating for the patients and getting the data that we were finding out there. And about the same time, Kevin Helliker, one of the editors of the Wall Street Journal, contacted me because he himself had an aneurysm and he had read the literature and wanted to know who in the family should be imaged. And I said, you know, you're an editor. Can you just talk to my families about how hard it is to get these findings that there's a genetic component to this disease out there into clinical care? And so he did a front page article on Tyler Cayley. And the article originally would have taken up like 7 pages of the Wall Street Journal. And Thomas Burton, the second author in this, came in and cut it down because he talked to so many of our families and families with Marfan syndrome on how they were mismanaged. But Tyler's story ended up on the front page. And this really helped to change the way that get that information out there to doctors. And it's so hard to translate the research into improved clinical care. So put that in the back of your mind. Like, I think, Patty and Mark do an amazing job taking care of patients here in Boston, but that has to spread across the US. So we'll talk a little bit more about that in a minute. And Kevin went on to win the Pulitzer Prize for that article. So the night he won it, I called him up and said, you owe me. I can get whatever I want on the front page. He was like, yeah, I haven't called. He's still an editor at the Wall Street Journal, but I haven't called him that favor. So we've collected families, like Tyler's families. We're up to about 1,500 families, and that translates into about 10,000 people in our research. And that includes patients with SMDS. And we found a large number of genes. Our lab, this is not just the work of my lab, but the majority of these genes have been identified by my lab, and they're all in clinical testing worldwide. And we still have a lot more genes to identify. So that's a major focus of the research that we're going after. And I just want to mention that the work with the John Ritter Foundation led to the American Society of Human Genetics to award me their Patient Advocacy Award in 2023. And that was quite an honor. And it is coming to patient meetings like this that really makes the work that I do, and I'm sure Patty and Mark feel the same way, so satisfying that we're getting, you know, what we're doing in our research is actually getting out to improve care. So this is a family that saw that Wall Street Journal and contacted Tyler's mother and said, who found the gene in your family? Because this was a family that had a lot of dissections and didn't have Marfan syndrome. And so Debbie McMillan, Tyler's mom, referred the family to us. And I went to see the family and I flew to where they lived and I met them in an auditorium at their local hospital and said, really need to recruit everybody in the family. That's how we can find new genes. And this is what the consent says and so on. And this individual here got up and he sits between his father dissected, his two children had dissection. And so he has to carry the defective gene. He gets up and he got up and said, you know, I have really bad coronary artery disease that started in my 40s and I don't have any risk factors. Could it be the same gene? You know, my father had it, I passed it on to my kids. So, and I said, I don't think so because an aneurysm, the artery gets bigger. In coronary artery disease, it blocks off. And I said, it's probably two genes. And then I asked if I could examine everybody who had survived a dissection. And so they pointed out to me that they all had exactly the same rash. Can you advance the slide? And it looks like this net-like rash all over their skin. And I thought, well, that's weird. And it's a rash called livedo reticularis. But it wasn't until I was flying back on the plane that I remembered that this is a rash due to the small arteries in the skin getting occluded. And so that was the first hint that maybe ACTA2 was causing blockage of arteries and aneurysms. So we went on to find ACTA2. They have this mutation, arginine 149, so different from the MSMDS mutation. And here is everybody in the orange carries the variant. And you can see everybody with dissection has the orange around their symbol, including this guy who got up and asked me. So we went back and got the history of the coronary artery disease. And now you can see that all these individuals with this early onset atherosclerosis have the ACTA2 mutation. Like this guy here had his first heart attack at the age of 30 with no risk factors. So really early onset atherosclerosis. So ACTA2 can cause aneurysms and some mutations cause aneurysms and early onset atherosclerosis. And about the same time when we found the gene, we started reporting out to families in our study that we had found the gene causing the disease. And the week that I reported out to this family, this young girl here had a stroke at the age of 16. And it turns out she carried a variant, but it's a different variant, 258C. And from what I understand, you've already heard that this variant is like a later onset SMDS, but without the problems with the GI tract, the eyes, and the bladder. So her stroke was due to this ACTA2 mutation, and we found other families, and this young boy died at the age of 8, has this 258, after he had his first stroke at 5. So some of these patients can present as early as SMDS patients. So we went on to publish all this data. I actually sent it to the New England Journal of Medicine, and the reviewer said there's no way one gene is causing aortic disease, moya disease, and early onset atherosclerosis. And I sent it to another journal called Nature Genetics, and they ended up publishing the story. But it was really very controversial at the time. So that one gene could cause all these problems. And after I published this, I started getting contacted by physicians and families where they had children with very early onset moya-like disease, aortic disease starting very young, And it turns out, we found out that all of them have exactly the same ACTA2 variant mutation, not the exact same mutation, but disruption of the same amino acid, that arginine 179. And so we went on to publish this as a syndrome. I have to tell you, this is the hardest paper I've ever written in my entire career. And I'm up to almost 400 publications. And it's because I'm not a pediatrician and there's so many complications and it was so hard to put it together and be absolutely accurate. And we did have very small numbers. But one thing that I think every scientist tries to do is to be as detailed and as accurate as possible with every single publication. So it took me quite a while to write this. And I mentioned that it's a multisystemic smooth muscle dysfunction. And so they picked that up in the naming of syndromes and named it multisystemic smooth muscle dysfunction syndrome. And I had the option to name it Milewicz syndrome, but I didn't want to do that. So I said, go with that. But I actually think the multisystemic should be dropped because it's hard to say. Even MSMDS is hard to say. And I think multisystemic smooth muscle dysfunction gets the idea across. There may be overlap with some of the conditions where they just have GI problems, but this is the only syndrome that is causing disruption of all the smooth muscle cells in the body. And so, so we went on to write the first guidelines for this. Once again, it was very difficult to put this together. We had a lot of collaborators providing their patient information. By then, we had set up so we had this cohort to find all the genes that cause aortic aneurysms and dissection, and that's about 10,000 people. But we also had the Multisystemic Aortic Consortium, so that once we find a gene, we can define how to manage those patients, when to do the surgery. Are they going to go on to have other problems with their arteries? And so by this time, the Multisystemic Aortic Consortium, or MAC, was established. And so these patients by then were going into the MAP consortium. And you may ask why I called it the Multisystemic Aortic Consortium.
It's a gorgeous.
What was that?
It's a gorgeous place.
It's a gorgeous place. The family that funded the start of the patient registry is one of the richest families in Canada, and they themselves are involved in the aortic disease, but they offered to have the first meeting at their villa and vineyard in Tuscany in Multisystemic. So I named it MAC, and hopefully Apple won't come after me, but I named it MAC with the hope that they would continue to fund the meetings and the registry, and they have supported it 1,000%. In fact, I just got back about 10 days ago from another MAC meeting in Tuscany and drank a lot of their wine. It comes out of their way too much wine. So, but we've published a lot of other studies, and I'm not going to go through all of these, but I think the treatment guidelines were really critical to get out all the complications and what we knew about it. Like in there, we say, don't just fix the first part of the aorta or just the first part and the ascending. We say, go ahead and if you can to fix all the way up to the arch, because we know they go on to have dilatation. In SMDS patients can go on to have dilatation of the arch and information like that. And then we also, and I think, Mark, you probably talked about this, there's other variants that are rare that have overlap with SMDS. And so over the years, I've been contacted about all those patients and really tried to work that out. And then we've put the SMDS patients in with all our ACTA2 patients and all the patients in the MAC to really look at age of onset. And only ACTA2 and 2 other genes will cause childhood onset aortic disease. And so that's one of the advantages of the MAC is we can compare the data of the SMDS to other like early onset Marfan syndrome or early onset Loeys-Dietz syndrome and be able to say what overlaps and what's different. And are there things we do for Loeys-Dietz that may potentially really help SMDS patients? And then more recently, so when the New England Journal reviewed that original ACTA2 patient, one of the reviewers said that I was even making up the data. It was so outside the box. And that really drove me crazy. Like I said, I've never had anything retracted and I never want to have anything retracted. And we had very rigorous data, but it was just so far outside the thinking of genetics at that time. And so we really have been working hard and trying to figure out how the variants in this one gene cause so many different diseases. And I've had a very talented postdoc, and now she's part of my faculty, Kelly Kortler, who really worked on a very major paper, and I'll talk about those results. And then Anita Kaw was an MD PhD student. She's left my lab since then and gone on with her career. She's training to be a cardiologist right now, but she worked on the mouse model of this disease. And so I'm just going to go over briefly where we are with these and not go into tons and tons of research. I'm going to give you like a bird's eye view from the top. Because believe me, if I start showing you the data, everybody will glaze over and go to sleep. So we know that these are the complications, the cerebral vascular disease, which appears to be a combination of the large arteries, the distal internal carotid getting included, but also blockage of some of those smaller arteries in the brain. And then the lung disease, we really need to understand this better and do a better job of managing it in children from the day they're born, and take on what they do for cystic fibrosis kids and really protect the lungs. Because the lung disease, I think if it's better managed and more aggressively managed, that it won't lead to some of the problems we're seeing in the 20s with people with lung disease. And then the aortic disease, we can manage that. It's not fun to have surgery, and I'm sure the patients in here know that, but it's plumbing, and we can go in and fix the plumbing. That's the easiest thing to address of all of this. So we really wanted to focus on this part because we also have found genes for Moyamoya disease and a lot of the genes we think act the same way that Moyamoya, the other genes, as ACTA2 to cause Moyamoya disease. And I just want to remind you that this is a cartoon of the protein here, or just the linear where the amino acids of the protein. And these are all the variants that we find in families with thoracic aortic disease. Here's 179 and 258. And then these two variants cause early onset atherosclerosis, but we have a paper that's in press that defines which of these genes cause early onset atherosclerosis using the MAC data. So it's lots and lots of variants in the gene, and it's only a few that cause disease. And so what we really thought was that for some reason, when you alter what's a protein inside the cell, and it's a protein that allows the cell to contract, like all our muscle cells contract, we thought that it was causing the cells to grow and migrate too fast, and almost like a tumor cell. And that's really the way I think about the Moyamoya disease. It's like a tumor of smooth muscle cells. And so when you look at an artery, the smooth muscle cells are the red cells here, and there's two thin layers on the outside and the inside. But here's a patient with Moyamoya disease and that distal internal carotid artery. And here's this layer out here. And then you can see the inside, all this is supposed to be open for blood flow. And you can see it's filled, and all these little dark dots are cells. So it looks like a tumor has grown into the artery. And so we really use that as a basis to start looking at this. We worked out, set up a bunch of models, and this is really what you want to do to understand a disease. We got skin biopsies from some of the patients, took them back to pluripotent stem cells, and then differentiated them into smooth muscle cells. We made a mouse model, and Nancy Pereira and her daughters, Olivia Pereira Cohen, a foundation really helped fund this. And as we heard last night, Nancy lost her daughter fairly young, but and then once we had the mouse model and the preliminary data, I got an American Heart Merit Award, which is the largest grant of that the American Heart gives out, and they only give out one a year. So this was really an honor. But they realized how important, like nobody knows what causes Moyamoya disease. And even beyond SMSDS, it's one of the major causes of stroke in children. And so they really supported this work also. And then finally, we explanted smooth muscle cells from mouse and human aortas that we had gotten from patients. When the aorta comes out, we can take it and actually grow out the cells in the aorta. So using this resource and like 8 years of work, we figured out what's going wrong. And so when we are in the embryonic stage and our cells are dividing, we start making lineages of different types of cells, okay? Because we're from just one cell, we grow up to millions of cells to make the body. And so as cells divide and grow, they have to differentiate depending what the type of cell they're going to become. So they can differentiate to become liver cells or heart cells, but some differentiate to become smooth muscle cells. And those are basically doing all the contractile function throughout our body. Our eyes contract our gut contracts using smooth muscle, our bladder. But every artery in your body, every time a pulse pressure goes through the artery in your body, your artery contracts a little, okay? So, the arteries in the brain, the stem cells first become neural crest cells, and these neural crest cells go all over the body, but they go on to make the smooth muscle cells, especially in the first part of the aorta and up into the brain. And so typically these neural crest cells, because they have to go all over the body, they proliferate and migrate very rapidly. But once they end up in an artery, they stop migrating. They turn on all those contractile proteins that they need to contract, and they sit there, they don't migrate, and they don't proliferate. They do a little bit as people grow, but as adults, in your arteries, you should have little to no proliferation or migration of your smooth muscle cells. So our hypothesis initially was that with the arginine 179, that something was happening that caused them not to become smooth muscle cells, but to stay like stem cells and not differentiate completely and continue to proliferate and migrate like a stem cell. And that turned out to be the case, and that was Callie Portler's work. And it turns out that smooth muscle alpha actin is a contractile protein, but it also moves into the nucleus of the cell to drive differentiation of the smooth muscle cell, something that nobody had ever known before. And so that was a really major finding and increased our understanding of what drives smooth muscle proliferation. But at the same time, there's lots of literature out there that if you have these stem cells, one way to drive that differentiation is make them stop taking up sugar as a source of energy, instead turn on their mitochondria and start using something called oxygen consumption or oxidative phosphorylation. And all our muscles in the body use, I'll call it OXPHOS, but you use your mitochondria for energy, not taking up so much glucose. And so we hypothesized that if we just took the ACTA2 mutant cells and gave them something that would drive OXPHOS, that they would differentiate. And that turned out to be the case. And the most important thing is they stopped migrating and they stopped proliferating. Like that was shut down and they turned on their contractile proteins and became more like a normal smooth muscle cell. So we've been working on this to really see if that's what's causing the lesions in our mouse model, causing more and more disease in our mouse model. So we take our mice, we do a minor injury to their carotid artery, and what happens is that they end up having strokes, and that's just shown here. Here they end up having, and they can die of those strokes. And here is showing that they actually have some death of the cells in their brain. The green things are control mice. And then this is one mice that didn't have any death of these cells, but this one you can see the green dots are totally gone. So in some mice, there's pretty significant cell death. And we looked at two different parts of the brain that are very sensitive to how much oxygen they get, and there was some cell death there. And they also the mice end up being, with that injury, end up being a little bit confused and not able to walk properly. And that was just in the mutant mouse, not in our control mice. And so we also looked at the lesions. So what happens with this is that we injure the control mice and the lumen opens back up after the injury. But look at the lumen in our SMDS mice. It's completely filled with cells and looks exactly like those human lesions. And then here we've given the mice NR, and we start the NR when we do the vascular injury. And you can see here, it doesn't make any difference in the wild type. It's still wide open. The stuff in the middle is like red blood cells and stuff that just doesn't get washed out. But here's the SMDS artery. You can see now it's wide open. The cells did not proliferate and migrate into the lumen and occlude it. But at the same time, the artery gets bigger. And all of you know that part of this, findings on imaging of the neck and brain in SMD patients is that the carotid arteries are bigger. And so I sort of wonder if this sort of is going on, off and on, sometimes even in the external carotid artery. And then here's our data over here. It's kind of hard to see, but this is the days after the injury and how many mice have died. And you can see in the SMDS, after we injure the artery, that 30% of the mice die of strokes. And if we give them NR, none of the mice die. So it makes a big difference in the mouse model. And this is just to show that not only do they not die, but those neurons that are dying don't die either, the neurons in the brain. So here's the wild type and two of our mice, this one having more severe stroke-like symptoms and a complete loss of those green neurons. And here you can see with the NR treatment, those are restored both in the hippocampus, one part of the brain, and the striatum here. So once again, this is wild type. These are the two examples of two mice. And then here's what happens with the NR. Pretty amazing response to the NR, and this is just quantifying this. So all these data are in press in Nature Communication, and it led us to start a clinical trial. So nicotinamide riboside, I will call it NR, is available over the counter. The formulation that the FDA approves for clinical trials is Niagen. Remember, when you buy stuff over the counter, essentially nothing is controlled by the FDA. So they do have one formulation where they know it's MAGE corrective and it's active. And what they say in terms of the amount you're taking is really truly what you're taking. The rest of it, don't know, okay? And so we started out with Niagen, and I understand that it's become so popular, popular, not in SMDS patients, but for many other conditions, that it's actually it's hard to get, and the cost has gone up significantly. So I think somebody will get on it, but soon, in terms of making another form that the FDA will approve. So there's a little bit more competition than just niacin. So initially we wanted to say, okay, so we had this drug that works on it's a vitamin actually. It works in the mouse model. Does it work in humans? So our initial work in terms of the patients was just to ask the simple question, did it decrease the amount of sugar that was taken up by smooth muscle cells? And we can measure that by PET imaging. We just wanted some marker that this was also occurring in humans. And so we did a few patients on this clinical trial. This is just a PET image to show the aorta here does take up glucose, and that's pretty unusual because, like I said, in a typical aorta, there would be no glucose uptake because all the energy would be through the mitochondria and not taking up sugar. So we started it where we brought patients to Houston, did a bunch of baseline studies, echoes, and did the PET imaging, and then started them on NR and brought them back. But it turned out between our patients, and this is just our clinical trial, everything we do in patients has to be approved by the FDA. So this is just the approval of what we started out with. So what we found was that there was increased glucose, but it was difficult to measure whether it goes up or down. Turns out that the PET imaging just isn't that sensitive. But we did see PET imaging is used mostly to pick up cancer. So it's because cancers take up a lot of sugar too. So it just turned out not to be sensitive enough. But in the meantime, the patients we treated and then other patients started Niagen reported back just really hard findings that it worked. First of all, essentially all of the patients have had, except for one, has had their blood pressure go up. Okay, so that means instead of being hypotensive, they're getting better blood flow, and that includes better blood flow from the brain to the brain. So also patients that have that sort of brain fog or difficulty thinking at times, all of that went away, and energy levels also went away. And decreased energy levels also improved. And the rise could be 10 to 30 millimeters mercury. And so one thing, if you're on Niagen, please monitor the blood pressure. And keep in mind that if the blood pressure goes up, yes, the cerebral perfusion gets better, the energy levels improve, but at the same time, that may trigger the aortic growth to increase. And so I would recommend, if you're starting Niagen on your own, to make sure that on yourself or your children, that you make sure the aorta is carefully monitored. And for children that haven't had their ascending and root, that can be done by echo. If that's been repaired, you need to watch the arch and the descending aorta. And really, I would counteract it with blood pressure medicine. And right now recommend, and whatever is currently recommended, there's a debate over whether that should be losartan or a beta blocker or some combination of that. And then we have had patients that haven't voided their bladder in their entire life. And on Niagen, they finally voided their bladder for the first time. And then somebody just reported to me at this meeting that their child had been constipated his entire life, and that improved on the Niagen. So we have some hard data. The blood pressure is very hard data. The bladder voiding is very hard data, but we want to make sure that this is not a placebo effect. So we're starting a modified clinical trial where we're discontinuing the PET-CT imaging, but instead doing a lot more to measure things like, is the cerebral cognition improved? Is there more blood flow to the brain? And we also want to look and see if there's any effect on pulmonary function tests, but also to really understand that better. And then make sure that the aorta is carefully watched during this. Now, this does not address whether Niagen can prevent the Moyamoya disease. That would be a different clinical trial. We want to get this one done in the next year and just say, yes, it works. And that we, and not all, may not work for all patients, but we want to make sure that we see changes and we document those and then have hard evidence that it's making a difference. Placebo effects can be very strong. And so this is really critical to say that what we see in mice is actually occurring in humans. So then the next question would be, does it prevent cerebral vascular disease or help to modify it? And I've got to tell you that already other children with Moyamoya disease due to other gene mutations are being started on Niagen based on the data in the SMDS mouse. And we're having very encouraging results from that. But that's not a clinical trial that's being used in children that have such severe Moyamoya that they're going to die unless they try something different. So I think between these other causes and SMDS that we can really have it be able to figure out whether it does anything in preventing Moyamoya disease. And there's reasons to think it would help with the blockage of those small vessels in the brain too, and open those up. So we'll see. Okay, so the lung disease, don't understand much about it, and we've been trying to work on that. The first thing we did was look at pathology in the patients, and we had infant controls and adult controls, and a couple of young children that unfortunately passed away at a young age. And then this 30-year-old woman was Kimberly. We heard about her last night when she lived in Dallas, which is north of Houston. And she had come down to see me on a yearly basis, and we were following her. And she said, every single time she came to see me, she said, if I pass away, I want to make sure that my body tells you something about this disease. And so a lot of she unfortunately passed away at the age of 28 of a stroke. And so we've used her samples to look at the arteries to show that in her arteries, every single artery had some degree of those smooth muscle cells moving from the wall into the inside. But it shows up in the brain much more because the brain's totally dependent on blood flow for its function. But we also looked at her lungs here, and I'm not going to go through it, but it's a combination of the arteries being occluded, not surprising, and that causes something called pulmonary hypertension, and many of you know about this. But there's also a problem with the way the lungs develop, and then they end up, usually you have a lot of every single one of these little lines is a place for oxygen to get into red blood cells. And then what happens in the lungs is those spaces get large, and that exchange most likely doesn't happen as well. And in addition, they have trouble getting the air back out of the lungs. So we're working on this in our mouse model. At baseline, not much of a phenotype, but when we injure the mice, they end up with both more emphysema and more of the thickening of the arteries of the wall of in the pulmonary circulation. So we want to use this to go ahead and test Niagen to see if it makes any difference in that disease. So that's it in terms of an update. I think that we really need to get out better management of the lung disease so it can be started at birth. And then, like I said, I really think that we can move into a clinical trial, not for Moye-Moye disease, and see if it works, both in SMDS patients and other patients with Moye-Moye. So we can get that information a little bit faster. So I just, I've been involved in patient advocacy, as I started out at the beginning saying that, and just want to bring up some things that I think that you as a group need to think about. I mean, and specifically, what do you want out of this organization? I think number one, and we heard this very strongly last night, is support and knowing that you're not alone, and for the patients that they're not alone. And this community is doing that very well. And Maimonides said that you make friends by opening up and knowing people for a long time. But when you meet somebody that has a shared passion or a shared mission, you bond immediately. And you could see that over and over again last night. And so I think that part you're doing very well. I think the next thing is getting out information to patients and doctors. And I think that really needs to step out. I'm amazed at the job that Patty and Mark and the other doctors at Harvard do in managing this patients, but that has to get out to every single doctor and across the US. And the next set of treatment guidelines need to get out. And so Patty, on their way?
Yeah, this afternoon we are presenting the Delphi consensus.
That's very good. So let's
Following
get
the
that
step.
out. Okay.
Only the legacy.
So that has to be pushed out because
Yes.
you have to standardize the care. You have to get the information out to every doctor out there. Not everybody can travel to Harvard, and in emergency situations, they certainly can't. And you have to have expertise across the country. And there's areas like, I know in Houston, we've done more aortic surgeries for SMDS patients than they've done at Harvard. So, there are other areas, people that are building this expertise, but Patty and Mark have really tried to focus in on getting everybody here and getting the studies done. So the data really needs to come out of the group here and to get those treatment guidelines. And then the next thing is obviously you want to support research and hopefully a cure. And I think that it's good to support any and all patient registries. Would it get out of the Harvard registry is going to be different than what we do with the MAC registry, but that's where we go for clinical trials and other things. And the registries, before you join them, they have to be open to anybody to use the data. And I know that the data is now going into Sanford. I've never heard of this company, but it may be a valid company. But I think if you have two registries already, do you need a company registry? And I think that's something you need to discuss. And also, once you pass it over to a company, I think they indicate you own your own data, but what happens to that data if they go bankrupt? And these companies go bankrupt over and over and over again. In fact, the Marfan Foundation spent $500,000 on registries and got nowhere because every time they started with a company, it went bankrupt. And so MAC is the only registry right now in the US for Marfan patients. So keep that in mind, and I think it's fine, but I just want to make sure everything's clear, and then also what happens if the company shuts down. And then encourage any and all research. I'm sure Patty's going to go through this, but there's another group in Dallas that has been working. They made their own SMDS model. And to be honest with you, I think they made a better model than our model or even the Harvard model in terms of gene editing. Because what they did is the mouse genome is not the same as a human. So they took that segment that needs to be edited and put the human segment in there. Still makes the same protein and everything, But when you go to do editing, you have to be aware of all the other amino acids around it. So they set up the right mouse model to start looking forward to human editing. And they have made the mouse. They've done the studies in those iPSC cells to see how it works, and they've shown it in the mouse that it's worked. But when I called up and said, you guys really have to have this group come and present, it was like, no, the schedule's set. I mean, think about how exciting it would be for somebody to come here and interact with you and see the patients. That's an incredible encouragement for researchers. You have to open the door to everybody. And this group is led by Eric Olson, and he's already well on his way to curing muscular dystrophy with gene editing. And you are so lucky that, and he definitely, even for his past work, he deserves a Nobel Prize. He's in the American Academy of Science and Medicine. He's received every award except for a Nobel Prize. His lab is amazing, and they are really pursuing editing for all the muscular diseases, the cardiac diseases, and now they started to work on smooth muscle diseases. So they're really focused on muscles, and to have that lab with that expertise working on your disease is amazing. And so make sure you are welcoming to everybody. And it's another reason to make sure those registries are open to any researcher, because you don't want them to have a cure and suddenly we say, oh, you can't have our MAC patients, they're ours. No, they would come to us and we'd say, here's what we have, here's the de-identified data, the ages and where they are in the disease progression. And then we would contact the patients to see if they were interested. And that's what you want a registry to do. And then support anything they wanted to do on a clinical trial. That's where the cure is going to come. Don't lead it to one group. And the other thing about having multiple groups is then the competition goes up. Come on, we live in the US. We know competition is good, and it is so good in science. So please don't exclude researchers from coming here and talking to you, even if they're not at Harvard or Houston. Okay, so that's about it. And just want to mention in particular Kelly Portler and Anita Kaw, and then David Murdoch isn't up here. He was on the first slide, but he's been helping with the clinical trial. He's an excellent has been an excellent addition to my group. So thank you, and I'm happy to answer any questions.
All right, I've got three of them. So I'll start with number one is you didn't mention the dosage of NR in terms of milligrams per kilograms, because I think it's standard, it comes out of 300 milligram tablets. What are you seeing in terms of dosage?
I can't remember the exact dose that the FDA approved. I can go ahead and send that out and send it to so that everybody knows. And I want to mention the second phase of going into, so the first phase, the PET imaging, the FDA approved it under a week. In February, we went in after our IRB approved it into the FDA for approval, and it took it's just been in the last couple of weeks they approved it. And so remember that all these cuts to the FDA and to the NIH are really going to slow research to a crawl. So please support the NIH, the FDA, the CDC. All of these institutions are there to protect you and improve your life. And you want the FDA overseeing any drug that goes into your mouth, because things like thalidomide happen which was never approved here, but was approved in Europe and led to a lot of birth defects. And you just need somebody, an agency to look over it, but I'll send that out to everybody.
So should all of our kids be on that?
The trial, just,
Well, I
Emphasize
think
the
you
try.
want to get to just, I think that's up to you. And, if you do put your child on it, like I said, it's over the counter. It's a vitamin. It's very benign. But if you do
the blood pressure control.
every single day, the blood pressure needs to be checked. And blood pressure cuffs are cheap.
Do
And if you join the trial, we'll give you one.
you have to do the blood pressure control if your child's already had an aortic repair? Is that still important?
Yeah,
It's still important because you remember you got the rest of
rest.
it and you got your carotid arteries and other arteries where aneurysms can form. We didn't get to number
That's
two.
okay, that's okay. But my second question was gonna be about, obviously, you talked about the role of NR with the OXPHOS process. I'm wondering about CoQ10 as well too, and
That
would
feels,
that be beneficial?
okay, so if you look in SMDS cells, the mitochondria are just in smooth muscle cells, the mitochondria are poorly formed. They're just not particularly functional. So I would say my gut feeling is that with NR to boost those mitochondria, that's when you want to come in with the coenzyme Q.
So both of them together, NR plus CoQ10 might be beneficial.
Yeah,
Okay, and then the third question I have.
I mean, that's just a hypothesis. Okay, let me make that clear.
And the third one is, you mentioned Dr. Olson, and I'm wondering if any of his MDS stuff has been published. at all.
Yes, it's out in
Yeah,
circulation, it's
yeah.
already published.
I'll talk about it. We've been in
Thank you.
contact with Eric, so.
Yeah, I know, I think we asked you if you wanted to do back-to-back papers, and you said no.
No, we've been in contact recently. He's collaborating. He's not taking it to clinic. So he wants to work with us because we're trying to take it to clinic. So
Mhm.
it's really good.
But let's get them here.
Yeah, they couldn't make it. I did talk to,
Mhm.
so it was too short of we got your email very recent.
Yeah.
So we spoke on the 27th with him, and he or the postdoc also couldn't make it.
When my daughter got diagnosed at the end of last July, and I had no idea what it was. Like I said, I took a snapshot of her genetic results and sent them to Dixie, who said, yes, this is what your daughter has. And then I began researching very quickly. And I did find your clinical trial with the nicotinamide riboside. It didn't say what brand it was, but then I researched and found True Niagen to be the best brand of it. And that's why I ordered it. And I did, because it's very expensive. It's $200 a month for me to order it. So I did reach out to True Niagen and said, hey, can the MSMDS kids get a discount on this? And they did reply back and said, yes, we want to work with you. Please give us the contact.
Yeah, it's on my list of things to do, is
Okay.
talk to Nigel.
Yeah.
And we will
I
provide
sent her your
that.
way. I was like, don't talk.
Yeah, so we'll provide the Niagen at no cost for the trial part. But yeah, I run a huge research program,
Yeah.
and so it's hard to keep up with everything, but it is on my to-do list to approach Niagen, not only to cover the cost of the drug, but also to support the clinical trial.
Okay.
Because I think they're very anxious to show it works.
Yeah. And so my daughter sees Dr. Mussolino for neurology, but we live in Pennsylvania, so we actually see Dr. Stacey Drant down at CHOP. I think you might know her. She talks very highly of you. And she has said, whatever I need to do to help get Eva into some kind of clinical trial for you with the True Niagen. So if you wanted our kids in the clinical trial, how do we do that? Like, how does
On
that-
that MAC email that I showed you, it's just go
at the
ahead and
top.
email there. Can you go to the
Oh,
first?
Is it up here, Dr. Milewicz?
Oh, it's up there you can leave it. Yeah, it's up in the, just email there.
Okay.
Okay. I can't even read all my emails. There's too many that come in. In fact, I started Matt because we were finding all these genes and we didn't know how to manage the patients. And so, and once you find a gene, suddenly you become the world's expert. And then I was getting these emails from around the world. So now when I get the emails, I can just attach a paper, you know, or the treatment guidelines or something like that, which I think is what I did for Dixie when she contacted.
My daughter's only 2.5. We started her on the NR probably over a year ago. As far as we know, she hasn't had any white matter lesions or a stroke. She also hasn't had imaging in over a year and a half. So we'll see next week if she's had any changes to her brain. But we also found out in February that her aorta is beginning to dilate. And we didn't know about the blood pressure monitoring. And also, like I said, she's only 2.5. It's not easy to get a blood pressure on a 2.5-year-old. Do you have any like recommendations as a non-clinical person for me to try to?
Mark, any recommendations?
Yeah, tough.
Yeah, I mean, we can get blood pressures on 2.5-year-olds. It's just more difficult. Right, and so that's right at the age that everything's harder. So, you know, echocardiograms are harder, blood pressure is harder. Until about 3.5 or 4. But that being said, you know, we can still get blood pressures. We focus on the systolic pressure because when the kids are fighting really hard, the top of the two numbers. So when you get a blood pressure, you get a systolic pressure, which is the high number, and a diastolic pressure, which is the low number. If you have an automated cuff, or even if you do it like when a doctor does it themselves, the lower number is always less accurate than the upper number. It's just a matter of non-invasive blood pressure taking, but that's the way it is. So in 2-year-olds and kids who fight and stuff like that, we can at least get some information from the top number usually. But it's doable. So I can talk to you afterwards, but it's mostly about acclimation to the cuff, and even not trying to get the number every day, but like putting a cuff on every day, and just it's part of the day, put the cuff on, you blow it out, even if, you know, not fighting every day to absolutely get the number, but just for it to becoming a routine part of the day, and I stop fighting on that all the time.
So what's your
And then you can, if it does go up, and then you can start medications like the beta blocker and losartan that are hard to start when the blood pressure is a systolic of 80. Yeah.
Yeah, I think that we'll actually probably see you next week, but we can talk about maybe starting beta blocker.
Yeah.
If it's.
Yeah, I'll have to review the data, but I would say in general, aortic dilation in this disease, even in a 2.5-year-old, we usually put those kids on medicine.
Mhm.
We'll talk about it.
And once again, the aortic disease is plumbing. And these children, I don't, and correct me, I don't think anybody's dissected under the age of 10, right? What's the youngest dissection in your cohort?
Under the age of 10. No,
I don't think so.
no.
Yeah, so.
Not
I mean,
aortas. We do have dissections of axillary and
right, but we're talking
but
the
not
aorta.
aorta.
The aortas are the ones that, and particularly the ascending, there's something called a descending dissection that is not acutely deadly. It's the type A's.
Yeah.
So it's sort of a rule in children, and Mark, correct me if I'm wrong, but Shane says this all the time, that it's really, children tend not to dissect really young. And so that's good, but at the same time, if you start Niagen and the blood pressure goes up, that gives you an opportunity to, you know, start a beta blocker to bring it down. And none of the highest that the blood pressure has gone up is to 120, which is normal, but I still think that you want to keep it under 110. What would be your recommendation? For all our aortic disease patients, we say under 110.
Yeah, no problem.
Sorry.
I have to say, I haven't dealt with managing blood pressure in MSMDS because it's been,
Yeah, so
just a
low.
struggle
Yeah.
to have a normal blood pressure. So, except for, I guess, that's not true entirely, we have one child who with more progressive neurologic disease who's probably has a neural mediated hypertension. That said, for like the younger patients, who haven't been affected by that yet, I think it's age dependent. I think 110 would be fine depending on the age. I think that's a good overall recommendation for school age or younger kids.
And so, and it's not like the blood pressure's shot up to 140 or 150.
You're right, it hasn't
But-
ever shot from what I understand.
Yeah, and the Niagen, it goes like to 80 to 90.
Yeah.
It's typical,
We have-
not a big jump in blood
I think
pressure.
it's, and I just say, thank you, it's very encouraging actually to see the data, because that's the conversations, that we've had with the kids that were on Niagen in your study was exactly that, they felt better.
Oh, yeah, they're
really-
calling it
Very-
wonder drug.
Yeah.
Makes a big,
They're
it
doing
makes
really
a
well.
So just
big
quite a
difference in
compliment.
energy and thinking like one of the patients wouldn't sit for the PSAT without the Niagen on board.
Yeah, absolutely, I just want to make that point that it's great work and it's great to see
Oh,
translational work go to
Yeah.
the kids.
thanks. But we,
The
I just-
rigorous way.
I want to clarify on the blood pressure monitoring. Once somebody's on either Patty or Diana, once somebody's on the Niagen and then you periodically check their blood pressure, you wouldn't expect the blood pressure to change once you have had that transition to that medication,
we
correct?
don't, I mean, you wouldn't expect it, but we don't know that.
Because I'm thinking about the monitoring and adding that extra layer of monitoring. I know it's cheap to get a cuff and that kind of thing, but once you've established a new baseline, then would it be reasonable to expect periodic monitoring after that would be
Yeah, I
acceptable?
think once a week or once a month would be.
Yeah,
okay.
exactly.
So thank you for that. I just was sorry, Diane, because we're having a bit of a side debate here on text about monitoring, so it would be good to hear from you. So if I just heard you correctly say that monitoring would be good to do once a week or at least once a month, not waiting.
Starting Niagen, I prefer it be done every day. And then once you hit a steady, then once a week or once a month.
Once a week.
Why do the
once a
kids
month.
not, why does the blood pressure bother them so much?
It's just another thing to add in the day of the dozens of medications
Oh,
we give and
okay,
the other
got
things that
it.
we give. We're trying to simplify the routine for our
I-
kids,
Yeah,
especially as they get older and they become teens. It's hard enough to get the medication in them that they need to have anyways, and to add more things.
it's
You know,
just
they're not professional lab people.
But I think having that direction of once a week or once a month is helpful as opposed to waiting when your child is in an ER or goes to a doctor's appointment. You shouldn't wait that long in between. So thank you for the
Yeah.
guidance.
yeah. I myself have hypertension and I check my blood pressure twice a day. I'm like obsessed, keeping under control. Okay, thank you.
I have a question.
Sorry.
There are three Zoom questions. Yeah, okay. Well, first, Ali, Levi got diagnosed when he was 2. So it was like you're normal, wait a second, now you're not situation. So, I could try to give you some tips for getting her blood pressure. That worked for Levi because he went from screaming and hating it to being fine with it, like super quick. And you just gotta be patient. And gotta try all the things. You never know what's gonna work. You don't know how many things we tried with him before it worked. I mean, last night he wouldn't eat until Dr. Mussolino fed him. And then he ate. You know, I just gotta try all the things. But I have a question. So with the Niagen, that's what it's called? Okay, you're worried about their blood pressure being too high, correct?
Not too high, but I think you don't even want it to be 120.
Okay.
Because it lowered the blood pressure, more it protects the aorta.
Mm-hmm. So what
So I think
about,
we want like a.
Caution. We have cerebrovascular disease in 100% of these patients. And there might be a trait from the brain. I'll talk about it, but.
yeah, because I was wondering, what about kids who have like high blood pressure? which is weird, but when my son had his open heart surgery, they said that they were monitoring to make sure it didn't get too low, and they were always worried about it being too low, and they said they were actually trying to get it to go down, not to stop it from being so high. So would he not be a good person to give this med to then, since his blood pressure is apparently already high?
Okay.
Yeah.
So I just want to say in general, about blood pressure control in this disease is that it's going to be individual. And so I think we're in danger of giving a guideline here that people are going to take home and do something. So I think that when we and the team in Texas do the same thing, is that you have to individualize it for what's going on with the aorta and with the brain, and pick the meds and pick some level that you are either trying to get back to normal or decrease from abnormal. So I think Levi, I think we'd have to do that slowly in clinic, looking at his data.
Yeah, we would never add anything without talking to Dr. Rios, and Dr. Rios would never add anything without first checking with you, so.
In general, it's a very complex disease, and so these are very complex questions for each child.
Mhm.
So yeah, that's.
I was just curious whether it would even be a consideration for a kid who's very not typical of the disease, I guess.
There's so many parts to it.
Yeah.
Sorry, guys,
I
but
think
it's
we
not
must-
an easy one.
He's had some challenges that are a little different, but it's definitely within the spectrum that Dr. Milewicz described originally, and so I think it's just the complexity we have to deal with for each kid.
Right, Zoom questions.
Don't go away.
Thought you got to go. So this question, I think has been answered at this point, but I'm just gonna ask it just to make sure that the people on Zoom heard it. But should all MSMDS patients be on the NR treatment? I think the two of you probably answered that.
Yeah, the answer is that it's a vitamin, and if you want to start it, I think it's fine. I will send out the dosage that the FDA approved, and once again, it's Niagen. And the price has gone up, and it's been more difficult to get too.
So,
So,
Diana, we haven't been recommending it. We have been
but
letting the
that's not a
families,
recommendation.
because I
That's
want
just
them to participate in the trial.
Right.
So we are not gonna test the right question and know the effect if you don't do this study that you have. So what is the best way to do it? What is your inclusion criteria? What kids can be sent to Houston?
Anybody can come to for this study.
Is age independent?
Yeah, the original one, we limited because we had to do the PET imaging.
Yeah.
And we did not want to have to sedate children to do that for a research study, but at this point, it's anybody.
Great,
Yeah.
thank you so much.
So what Patty said
Just-
was, what I'm saying is it's not a recommendation, but if you do consider it, then we'll send out the dose and monitor the blood pressure. But we would like to get people into the trial and try and absolutely show that it does have these changes.
I'm gonna ask is a follow-up. Can they do a washout before they go to your trial? If
Yeah.
they're on Niagen, and what is that period in your study?
I don't.
3 months to a couple
I
weeks?
don't
Like,
remember.
because I think that may be the.
I mean,
compromise.
I don't think we actually wrote it into the trial because I did not know so many people were starting it. Yeah.
Stop them.
That's a great segue into the next question, which is, do we know how many MSMDS kids are already on the NR?
Okay, if your child is on Niagen, raise your hand.
Four in the room.
If
so-
your child is not on Niagen, raise your hand. So pretty 50-50 or 40-60, pretty close.
50 and
Okay,
46.
that's a guesstimate. Thank you.